What's going on, everyone? Welcome back to the Rehab Science Podcast. We are back this week. I'm here with Kirsten for another PT talk about a specific condition. In this episode, we're going to be looking at patellofemoral pain syndrome, which is a mouthful, but essentially refers to knee pain that is in the joint behind your kneecap. Kirsten and I know in our years of seeing patients, this is probably one of the most common conditions we would treat in physical therapy.
Definitely.
Just a lot of people. It sounds like this really obscure patellofemoral pain syndrome. Most people have no idea what that means, which is kind of, you can understand, but it's also a little bit surprising because there's so much of this. And I think maybe it's a lack of education around it, but it's one that we saw a lot in the clinic. And I think we're kind of in an interesting area in Southern California. There's a lot of research out of USC on patellofemoral pain syndrome. So I feel like it's one of these areas that it's probably, of all the different pain problems in the body, I think it's probably the one I've had the most education on, and I've had it personally. I had had kneecap surgery in high school. My kneecap was in two pieces. It's called a bipartite patella. I was just born with it. It's a congenital issue, but a little piece of that was floating kind of near my patellar tendon. And so when I was in gymnastics and martial arts, when I'd land, it would hurt. And I had surgery for that. The piece of bone was taken out. But ever since then, I've been a little more prone to develop patellofemoral pain symptoms on my left knee, especially if I increase my running volume or do more squats or lunges, things that load the patellofemoral joint. So it's one that is personal to me. And like I said, we have a lot of research on this just in our area because of USC being close by. But yeah.
I've also struggled with the same thing in high school. When I ran track, so I feel like it's also something I've dealt with.
Did you have it on both sides or just one side?
Mostly just one side.
Yeah. Oh, that's true. You had a lot of knee pain in general with running. Like some was patellofemoral, like front of the knee, and some was IT band kind of stuff.
Most of it was patellofemoral.
Oh, it was. Oh, okay. Yeah. So as I was just saying, patellofemoral pain syndrome tends to be on the front of the knee, and there's a joint behind your kneecap. So essentially, your kneecap rides in the trochlear groove on your femur, which is sort of like it's kind of a track. And so the kneecap slides through that track. As you bend and straighten your knee, the kneecap slides up or slides down. And so there basically are situations where this joint can become irritated, maybe inflamed, and that can lead to pain. We used to think of this pretty much as a very biomechanical problem. It was actually referred to as patellar maltracking. So everyone thought that if you had patellofemoral pain, that you had a tracking issue and your kneecap wasn't sliding through that groove appropriately. There's cartilage on the backside of your kneecap. And, even some people who go in and have imaging done, they will be diagnosed with chondromalacia patella, which basically means a softening and wearing of the cartilage behind the kneecap. So you can get arthritis there too. But in most people, there's no signs of arthritis. There's nothing you can see on imaging. It's just they have pain. And like I said before, it was always talked about as this biomechanical, you'd have a tracking issue. And I'm sure you remember, like in our early days as PTs, everyone that came in, it was like we were trying to fix their tracking.
I feel like I did a lot of taping for a long time.
For sure. Yeah, and it's interesting, right? Like this research has totally changed as it's gone along. Like almost every musculoskeletal pain condition, there is a component of it that is thought to be related to biomechanics, but it's become such a more complex disorder. Different psychological variables, stress factors. Basically, we've found that the interventions that we were, when we were trying to change someone's tracking of their kneecap, oftentimes people would get better and you wouldn't change their tracking at all. Most of those interventions don't actually change the tracking of the kneecap. And it didn't really matter. You could look at their tracking before, go through physical therapy, they'd get better, and their kneecap would basically be in the same spot and have kind of the same tracking. And some of those interventions, like taping, I remember we'd always do that taping where we would, push
the patella over.
Yeah, we'd push it medially. It would look like, sometimes people would look like their patella was sitting too far to the outside, like it had a lateral shift or it had a lateral tilt, and we would take tape and pull their kneecap towards the inside of their knee and then tape it down. And for some people, they would really say that helped their symptoms. Of course, the tape wears out fairly quickly, but and there is still some research out there. I was going back and looking at the research. There is evidence for tape in some people, but I think more of the mechanism now would be not that we're correcting the person's tracking, but just that you're unloading sensitive areas on the backside of the kneecap. So there's different facets on the backside of your kneecap, and basically they can become sensitive like other structures. And if you can take some stress off of them, they desensitize and pain gets better.
I also feel like I hyper focused before I was a PT on the actual knee problem, and then went to PT school and then found out like my hip was incredibly weak. I pronated, there was a lot of other issues contributing to it, that as long as I slowly started strengthening all those things, it went away.
Yeah. Yeah, that's a big part of the research, right, is looking at the rest of the kinetic chain. So, of course, you have interventions that target the knee, whether it's like gradually strengthening the quads, maybe the tape. But then in the rest of the kinetic chain, there's a lot of research for hip intervention strengthening the glutes. And that was another one that was really mechanical in the beginning. There were these studies where they would have people do squats in sort of like a functional MRI, and they would see that, because like I said in the beginning, they thought the kneecap was shifted out of place. And then what they found in these studies is that when people squatted, it was actually their femur, their thigh bone was internally rotating or adducting. And so the femur was moving, which made the kneecap seem like it was out of place, but it wasn't the kneecap moving, it was the bone underneath moving out of place. And I think that was Chris Powers and some of them that originally looked at that. So it was still very biomechanical, but that, because it was the femur moving and not the kneecap, the muscles primarily that control your femur, especially those movements, are your glutes, your external rotators, your hip abductors, which are gluteus medius, minimus, gluteus maximus. So then a lot of the research shifted towards, let's strengthen the person's glutes so that they control their femur better, which will make sure that stress is appropriately applied to the backside of the kneecap. And again, a very biomechanical explanation, and it did help a lot of people, but the research more currently has shown that, again, it's a more complex problem. So you've got to think about other factors, just like all pain issues. You've got to think about the stress in the person's life, mental health kind of related issues, anything that can bring that threat to the nervous system and sensitize the nervous system. But you're right, that was a huge, almost every piece of content or program I give people for patellofemoral pain syndrome, especially in the acute stages, is really focused on glute strengthening. It's nice because while the knee is sensitive, you can strengthen the hip muscles and it doesn't put stress on the knee.
I also feel like, because then I ended up getting orthotics, but then the orthotics messed with some other parts of my feet. So I feel like starting at your feet is a little bit more, things can go sour, but you would know more than me at this point.
Yeah, yours was tricky. I think maybe the orthotic was too aggressive for you at the time, but there is research to support orthotics too, especially people who are heavy pronators and have patellofemoral pain syndrome. The same kind of idea. There often is this tendency for people with kneecap related pain where their leg collapses sort of in as they load it. They often go into a knee valgus position where their knee sort of moves medially towards the other leg. And so part of that can be farther up the kinetic chain with the glutes. Like if the glutes don't control the femur well, then the femur can adduct and internally rotate, and that can apply stress abnormally maybe to the backside of the kneecap. The other side is from the ground up. And if the foot pronates, that can lead to kind of medial collapse of the leg. So there is some research specifically in people who have a foot that maybe really pronates. I think it's a place that if you have kneecap-related pain, if you have pain on the front side of your knee, trying an over-the-counter orthotic like Superfeet or something that you can just, oftentimes the over-the-counter orthotics have the same outcomes as the custom expensive ones. So
I would definitely always say start there.
Yeah, like just get a over-the-counter one that has a little bit of a, like Dr. Scholl's, some of those are just the gel. That's probably not going to do much, but the ones that actually have a little bit of a hard shell that has a little bit of an arch support, slip those in your shoe and see if it changes things. So many of these pain issues are literally just changing the stress, just tweaking it slightly on your body. For something like patellofemoral pain, because it occurs in a lot of runners, sometimes it's just changing your shoes. Maybe it's having a few different pairs of running shoes and wearing a different pair each time you run just to alter the stress on your system. And I think we're kind of jumping around a little bit, but maybe some important symptoms to know if you're wondering if you have patellofemoral pain syndrome is that, like we said, it's pain on the front of the knee and it's behind the kneecap, so you can't usually palpate it. You could touch the front of your kneecap, but since the joint's back there, you can't reproduce the pain with palpation, which is a little bit different because the other thing that happens on the front of the knee is patellar tendinopathy. So that patellar tendon, which is, if you trace your kneecap down, there's a point, the bone forms a point at the bottom, and then right below that is the patellar tendon. And so that's, if you have pain in the patellar tendon, you can push on it and reproduce it. A lot of times that's referred to as jumper's knee, and it's often aggravated with a lot of the same things, jumping, things that work your quads, like squatting, lunging, stair climbing. So sometimes it can be tricky to differentiate between these because both patellofemoral pain syndrome and patellar tendinopathy can be aggravated by the same issues. It's usually activities where your quadricep muscles on the front of your thigh have to contract. And when they contract, they apply stress to the patellar tendon, but they also compress the patellofemoral joint. So
I feel like that one that was a little bit more point tender, like pretty obvious.
Yeah, it is. I think patellar tendinopathy is a little bit easier to figure out because it is so point specific. It's in that tendon. You can push on it and reproduce the pain. Whereas patellofemoral pain can sometimes shoot to different areas of the knee. It could shoot around the inside, the outside. It can kind of refer from the joint. But people will usually say there's a sharp pain on the front of their knee, kind of behind their kneecap, when they do things that are quadriceps dominant. So again, it's like squatting, stair climbing, running, sitting with your knee bent for prolonged periods. That's one.
I still get that.
Yeah, I do. Actually, I do too. My left knee will get that if I sit for too long, especially if I've done a bunch of like I've had a legs day at the gym or something that's a little aggravated, or if I've gone running. But they call that the positive movie theater sign. You sit and your knee's bent for prolonged periods, and then that recreates your pain. So those are some of the things that what the symptoms will be like and things that might aggravate it. And I would say in most people we saw, you could make a huge difference in this in that 4 to 6 weeks of physical therapy. This is one that when you can kind of get them to rest from the aggravating activities or modify them, maybe they're reducing their running volume or doing less stairs, or they're taking a little break from squats or lunges, something like that. If you give the tissue a little bit of a break and then maybe you focus on that glute strengthening, people get better pretty quickly.
Yeah.
I think they're like mine, I still have it. It's not like it's ever fully gone away, but I kind of know how to manage it at this point. What about yours? Do you still have it ever?
I don't run.
Yeah, if you don't run, you don't get it.
Nope, I don't have it because I don't run.
Not with stairs. You don't get it if you squatting a bunch. None of that stuff.
But I also had never strengthened my hip ever in my life until grad school. And now I do it every week, so.
Have you gone back to test running?
Yeah, I did. Remember, I trained for that half marathon for a little bit, and it was fine.
Yeah. So maybe, because you've done way more strengthening.
Yeah, I did none in high school.
Yeah, you were just running. Yeah, so which is another huge point, right? How many runners, I can't tell you how many runners that have come into the clinic and tell me I don't need to strengthen my legs, I run. And it's just such a different stimulus.
Totally different.
Yeah. The slow, heavily loaded strength training, there's so much research supporting 2 to 3 days of resistance training for runners, even for their legs. And so hopefully runners will hear that and implement it, because it does make a huge difference for everyone in terms of reducing our susceptibility to some of these pain issues and injuries, and patellofemoral pain is definitely one of those. I think one of the other interesting things actually with runners is that heel strikers tend to be more prone to patellofemoral pain because of, so you see runners that are naturally more forefoot strikers, they land on the front of their foot. Some are kind of midfoot strikers, some are heel strikers. I tend to be more of a heel striker, and heel striking, because of your heel contact in the ground, it leads to more stress being sent up to the knee joint. And so they do talk about that if you are a heel striker and you have knee pain, to maybe think about 2 different things. One could be, maybe 3. One could be maybe just a shoe with more support, more kind of a sole to it, so you have more of that external shock absorber. Another thing is to increase your cadence, so you just take more steps. You're not actually running faster, but you just take more steps. And there's been quite a bit of research showing that when you take more steps as you run, it reduces how much force goes into your knee. And then the other one is just to experiment with just a subtle shift towards midfoot or forefoot, landing on your midfoot or your forefoot. Forefoot strikers are different in that because they're landing on the front of their foot, all the stress kind of goes into their Achilles tendon and calf. So they're more at risk of like the Achilles tendinopathy kind of stuff, less prone to patellofemoral pain. But those are some things you can think about. I feel like there's so many people that running is kind of their main form of activity, and they've got knee pain. And so those are a couple of strategies to think about. But I think, so those are kind of some of the main symptoms, things that tend to aggravate this, how long it typically takes to get better. I think this is nice. There are some other issues we've talked about that can go on for months and months, and I think this one you can you can make a big change pretty quickly. What else in terms of treatment? What were some things you'd think about? Say somebody came in the acute stages into PT. What are some things like they're really flared up? What would you start
I
with?
actually did soft tissue at the beginning. I'd find that their quad was extremely tight, and just that alone would kind of relieve a lot of their pain right away.
Yeah. No, I agree. Yeah, that's kind of like what I think of in phase one. If you're going to break it down into phases, that phase one is all about desensitizing the joint. And I do think that's a place for soft tissue work, massage work. And because we know that the quads, tightness or activities where the quads contract, compress the joint and can flare it up, I agree. I think whether you're foam rolling your quads or somebody's actually getting in there and massaging them, kind of working from just above the kneecap up through the whole front of the thigh, I found a lot of people that really helped. I think, they probably, like most pain issues, you have muscles that are guarding and kind of spasming around the area. And if you can get those to relax, people tend to feel better.
I'd also usually do if they did a little patellar mobility, checked to see. I mean, everyone was different. Some people were restricted, some people moved too much. But doing a little bit of mobilization if it was restricted.
Yeah, which are really simple. And I think a lot of people don't know that if you sit with your leg out straight, your kneecap is supposed to slide inferior down, superior up, and then medial and lateral side to side. And it's supposed to move. I don't remember, they used to say that if you took thought about a third of the width of your kneecap, that's how far it should go each direction. Like you said, some people are hypermobile and it shifts really far, and maybe they're more at risk of something like a patellar dislocation. But you would find some people who were a little stiff there, or they were guarded, and sometimes just kind of mobilizing their kneecap up and down and side to side would help reduce symptoms. And I think some of that is probably freeing it up and getting it to move a little bit more, and some of it's just another sort of just getting things moving a little bit. That's a good point. So you can think about soft tissue mobilizations and massage in the beginning. We've got some of those patellofemoral joint mobilizations. And then I think the glute strengthening, right? Because that's another one we think about. We would do these exercises like side lying hip abduction, maybe things like clamshells. We had like the banded squat walks. What else for glutes? Maybe like bridges, like single leg bridges, double leg bridges. Any other glute exercises you like to use in the beginning?
Those are kind of the main ones.
Yeah. And everybody listening to this, for these specific condition episodes, I've created PDFs. So if you're hearing us talk about some of these exercises, there's YouTube videos. I have YouTube videos. I have a patellofemoral YouTube video where you can go and watch the videos, but also create a PDF that you can go over to my website, rehabscience.com, on the podcast link, and you can subscribe to the podcast and get those free PDFs. So this one, the PDF will have a few of the exercises we'd commonly use for patellofemoral pain syndrome just to get you started. But those are some good ones. We've got the mobilizations, both for the quads, the patellofemoral joint, glute strengthening exercises kind of in the beginning stages. And then a lot of the research over time, and then also calf strengthening. I think you want to think about the rest of the kinetic chain. So things like calf raises are good to implement. As the kneecap and the patellofemoral joint desensitizes, then you start moving towards more knee-centric, kind of knee-focused. You want to gradually load it, because if you just baby it and never challenge it, it will just have a tendency to stay sensitive. So it's that whole almost thing about graded exposure, like how can you put little doses of stress on the kneecap and get it to desensitize. So that's really where your quad strengthening comes in. So
a lot of it too is, looking in the mirror and training people to be able to feel where their knee is in space. I mean, you can strengthen the glutes and then continue to not recruit your glutes when you're doing those movements. So doing a lot of training in the mirror of people watching themselves do, and then also adding dynamic exercises like jumping and kind of that next level up and making sure they're recruiting the right muscles.
Yeah, I'm glad you said that, because I was jumping right to the strengthening of the knee, of the quads, but a lot of this is motor control in some people. So if you're looking at a runner, a lot of times it's runners, but it could be jumping athletes, even people just doing stair climbing and squats. Sometimes people will have quite a bit of kind of medial lateral, their knee will move side to side quite a bit.
Well, you see it in volleyball players when they jump up and they come down and their knees both kind of collapse in on each other. Mm-hmm. So they might strength train, but that you haven't retrained them to jump properly. Mm-hmm. So some of it was just proper mechanics.
Yeah, it's that kind of neuromuscular or motor control training. So it's if somebody has knee pain and you notice kind of maybe less than optimal form when they're landing or walking, you're right. Like you could do the glute strengthening, and there's studies on this where they do the glute strengthening and it doesn't transfer to function. So you've got to go over to a functional task. Like maybe it's a single leg squat and they do it in front of a mirror starting out. And so they have that external kind of feedback of, can I keep my knee lined over my foot as I do a single leg squat? And then slowly over time, try to move away from the mirror and just train your nervous system, kind of teach it how to control that movement, and then start adding load to it. But you're right. That's, you don't want to think, even though the glute strengthening just by itself can be helpful, you also want to implement exercises that help you transfer that to real life functional tasks. So I think that's great. And then, yeah, I think at the end of it, you've basically got hamstring and quad strengthening. Hamstring strengthening doesn't tend to bother, but as you get into more of those knee specific ones, especially the quad strengthening, so that might be things like wall sits. You could do leg extension, the leg extension machine at the gym. You could do...
I do a lot of single leg squats.
Yeah, single leg squats. You could do like a single leg bench squat, like where you do this, the eccentric, you go down on the painful leg, sit on the bench and come up with two legs. There's different ways to kind of build into this to gradually expose the joint to increased stresses. Sometimes just like cycling, like it could be on a stationary bike, something like that, where that tends to be a more provocative thing. It's just kind of getting... I mean, I think for me, it's been surprising. I tended to shy away from the leg extension machine at the gym in the early stages before I knew about it, because it would just always, it just seemed like it hurt. And now as I've done it more and kind of slowly built up the dosage of it, I can do it and not have any pain, and it actually really seems to help me now. I think just loading my quads that specific way. I mean, the research talks about over and over how important the quads are in terms of stability of the knee joint. And I remember at one point I had my quads tested, the strength tested on a dynamometer, and my left leg, that leg I'd had surgery on in high school, was 50% weaker than my right leg.
Wow.
In my quads. So it's a huge deficit. And it'd be interesting to test now, but I've really put more effort into strengthening that side.
Do you ever do single leg on the knee extension or just double leg?
I do single leg sometimes, but it is mostly double leg. I should drop the weight and do some single leg. But I feel like that deficit has gotten better, and I think that's true for so many people we'd see when they'd come into physical therapy, right? Like, and in the studies, you see this too, that when people have a pain issue, they often have a loss of strength and mobility. You find these sort of asymmetries. And so I think even if you might have patellofemoral pain right now and it's super sensitive, and strengthening your quads it's down the road. Like you think about that down the road, but it's something you want to get to help desensitize the joint and get rid of potentially some of those weakness kind of deficits that are often there in people who have this. What else? Anything else you can think about? It's not something there were surgeries sometimes for this, like a lateral release, but they really hardly happen anymore.
Rough recovery.
And it's really, the outcomes just aren't any better than just going through rehab. So the things I see really in the research are exercise, hip and knee strengthening, some research for taping, some for orthotics if you have a foot that pronates a lot, and maybe it's thought to be associated with the symptoms. But
I feel like foam rolling helps some people. It's for some reason usually made mine worse. I think the way I was putting pressure on things and I couldn't relax because it was so painful. And
yeah,
but
even a lot of the foam rolling has kind of gone out of popularity, especially the IT band kind of foam rolling, with research showing that you can't really make your IT band more flexible. I think the foam rolling is kind of like massage in general, where it's not probably changing the kind of function and biomechanics of your tissue, but it's, you're putting pressure on the nerves that go through there and give them sensation. You're probably it's another input in your nervous system, and that probably, and some people can help kind of reduce pain. But yeah, I think a lot of it's rehab focused. It's kind of going through those phases. A big part of it is behavior modification. Thinking about those things we talked about in the beginning, like maybe it's changing your running form, maybe it's running less, maybe it's changing your striking pattern. If it's aggravated with things like squats and stairs, maybe it's trying to do less of those things. If it's something like squats, it could be going to more hip bias squats, like leaning your trunk forward, doing more back squats, whereas like a front squat would tend to put more stress on your kneecap. Maybe it's a reverse lunge instead of a forward lunge. Anytime your knees go over your toes, it puts more stress on your patellofemoral joint. But the message with all these things is you don't want to avoid those forever. You slowly start to kind of work back towards that stuff. For too long in the PT industry, it was always like knees over toes is bad and all this stuff. And we know now that none of those movements are really bad. It's just you might currently be sensitive to them. So you just back off a little bit and then you gradually re-implement them. So think
I think that's mostly it.
yeah, so I hope this is helpful, you guys. That's kind of a patellofemoral pain syndrome, pain behind the kneecap in a nutshell. Again, I will put a PDF over my website if you want to get 3 or 4 exercises just to start with. My book does have a more comprehensive program for this in the knee chapter, so I will put a link for an Amazon link for the book down in the show notes if you want to check that out as well. And we'll see you in the next episode. Bye.